Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint podcast. Okay, welcome to the podcast. This is episode 11, and today we're going to be talking about the safety and efficacy of spinal manipulation in children. So the purpose of this episode is going to be to critically explore the use of spinal manipulation in a pediatric population, examining the evidence, safety concerns, and clinical best practices, and to spark a thoughtful, informed discussion around its role in modern healthcare. This is bringing me to two central questions that is going to be the focus of this podcast. Number one, is spinal manipulation safe and effective for children? Number two, when, if ever, should it be used in pediatric care? Okay, so we're definitely going to be looking at the evidence of efficacy, adverse effects, real-world examples, pediatric education in allied healthcare, and then also the physiological considerations. So first things first, I'll just lead us off. I want to be able to frame this episode the best I can by starting with an example. I'm going to share a quote that is on a chiropractic website. So I quote, "Nerve dysfunction caused by birth can result in weakened breathing, irritability, colic, difficulty with feeding and attachment, sleeping problems, and neurological defects. Undetected, these problems can sometimes lead to learning difficulties, asthma, repetitive ear infections, hyperactivity, and other health problems." This is what a chiropractic website has put as a means to promote what would be chiropractic treatment for babies. This type of advertising can be seen everywhere once you start looking into it. Babies are being adjusted all the time, especially you can see it on social media with no real guidelines on what, when, or how this may be appropriate, and that's a problem, right? Most of the time, there is little clinical reasoning for this treatment, and if there is, the clinical reasoning is based on some outdated philosophy or subluxation theory, especially within the chiropractic profession, and that is concerning. Does this raise ethical and safety concerns? And I would say it does. In an article from the Washington Post, pediatric surgeon Dr. Anthony Stans cautioned parents against chiropractic for babies, and he stated, I quote, "To my knowledge, there is little to no evidence that chiropractic care changes the natural history of any disease or condition." So framing the episode with that, I'm going to throw to what would be an author on this topic. There's a chapter in the most recent book by Giles, Jimmy, the OMT team, which was also co-authored by myself and Luke. There's the book. What does that quote mean to you when I read that out, Giles? And what is your opinion on what I kind of just said?
Well, there's a couple of things. Firstly, I wouldn't pigeonhole one profession because it's not just chiropractors. We know this. Osteopaths are doing the same thing globally, as well as other professions out there. So they're using these interventions. So although we've picked on one profession at the moment, it's a broad statement across a lot. When I hear the quote you said about from the chiropractor clinic talking about nerve dysfunction affecting things like cognitive development, that to me is fear mongering and scare tactics. I look at that as fundamentally an extract from Harry Potter. It's based on pseudoscientific, outdated concepts. It's not true. Yet as a new parent, I would read that and I would think to myself, geez, I don't want my son turning out to be a complete idiot like me. I'm going to get him cracked up to the eyeballs to make sure he develops properly. Exactly. And ironically, so I mean, that's one hand, that's absolute scaremongering from a perspective. I actually was training some therapists over in Asia many years ago who had a clinic, and they were using spinal manipulation on children to increase their growth, to make them taller when they were older. And they were saying to these parents, oh, you have to come in twice a week and it will, it's going to take years and years and years. But don't you want your kid to be taller? It's just complete unethical scare tactics. So when I look at that, I think to myself, is that person uneducated or are they unethical? Are they looking at that from a financial perspective? Scare patients into coming in for multiple treatments, scare parents to come in for treatments that may not be warranted or needed. The other statement about the evidence, I can't disagree with it, because in the chapter we went through everything and we were trying to be really fair. We've tried to give a fair view and look at the evidence, and we've tabled it. And at the moment, there really is no good evidence out there supporting the use of manipulation on children. And as an osteopath, I would always say to my students, if I'm not going to crack the necks of my kids, I'm not going to crack the necks of yours.
Mm.
And I'm a big believer in other modalities, which we'll talk about later. But yeah, that's my thought on those two statements.
There is obviously going to be an ethical component to this conversation. And coming down to three practitioners that pride ourselves on being honest people and ethical in our practice, I look at this and I find it hard to not be appalled, to be quite honest with you. Now, for some people, that may be shocking, hearing that people are advertising this way so that they can say, well, this is the problem through birth. Your baby is being birthed and they're not perfect. They have all these issues and irritability and problems. And if they're not feeding right, or if they're not breathing right, or if they're not attaching right, if they're not doing all these things, then you need to come in and we need to crack them. Right. Like, I find that deeply unethical. And I think that's problematic, especially being a father of two. And I know the position emotionally you're in when you have a new child, but it's actually quite familiar for myself. I want to hear your quick thoughts on that, Luke. That quote is not unfamiliar at all to us, right?
No, and that's what I was going to touch on as well, was the reason why we find those types of quotes on a lot of chiropractic clinics is it puts like each demographic and age group under one sun, like under one main thing of what the health professional is trying to achieve. So we were taught, like, from the moment you're born to the moment you die, you're prone to what we call vertebral subluxation, which so basically they're saying that everyone should have this sort of nerve interference cleared by sort of manipulation, which is why it's very easy to market towards families and pediatrics and things like that. So yeah, we were taught that for sure.
And obviously this is disclaimer that you came across with Giles being like, we're not trying to single out any profession, is true, but we do have a duty to kind of cover what would be one profession that has a very strong philosophical drive towards one-size-fits-all treating, and that would be chiropractic in terms of the subluxation theory. So that's why we're bringing that up. And obviously myself and Luke went to chiropractic school, so we understand a little bit more about that, as in you can probably bring us more perspective from an osteopathic perspective, and I'm sure there's just as many quacks in that profession too. But when it comes to the chiropractic, the problem, if you kind of zoom out with a bit more of a macro lens at this discussion, one size fits all approach from a chiropractor is that philosophy that, well, anybody on this planet, if they're going to have thoughts, trauma, or toxins, they call it the 3 T's in chiropractic, anyone is going to be eligible for a chiropractic adjustment. Now, it's important that I state they differentiate between spinal manipulation and a chiropractic adjustment, because spinal manipulation might just be cracking a joint, extremities. It can be spinal, it can be anything for the sake of whatever. A chiropractic adjustment is going to be specifically aimed at restoring nerve flow through what would be a subluxated segment. And it's important that we say chiropractic subluxation because it's different than a medical definition of a subluxation. When we're talking about a chiropractic subluxation, there is no real way in a medical sense to prove that it exists or it was real. The research obviously doesn't show that, but it does give them the justification to treat anything. Because every single person walking around, whether they're old, young, or middle-aged, whether they're an athlete, whether you're specifying in pediatrics, geriatrics, anything, it gives every chiropractor the opportunity to be a specialist, because everybody is going to be subluxated. That's what they believe. Is that pretty much? Did I cover that pretty fairly, Luke? Would you say?
Yeah, 100%. I just find it interesting too. I don't although we're targeting in on chiropractors. I've only ever really seen chiropractors do this sort of stuff. Maybe a few osteos here and there, but anyone outside of that, I'd be interested to know what their justification is to doing this sort of stuff on babies.
I would say it's very easy for chiropractors to justify their treatment if they follow that one concept.
Yeah.
It takes a lot of clinical thinking out of the equation. They're just focusing on one issue that can fit to every demographic. We exclude, nutrition and health and everything else. It's just that one thing. In the UK, osteopaths, we don't manipulate children. So we're not, as part of our general degree. Outside of the UK, I've seen, there's a very famous French osteopath who apparently is a world famous osteopath, who was on YouTube and Instagram cracking the pelvis of a 6-year-old boy to restore pelvic alignment. Now, so it is being done by these professionals or these mono interventionists. If you've only got one trick, if you've only got one skill, and that is a crack a joint, you're going to crack anyone and everything that comes in because you'll fit it into that one paradigm. Yeah. If you have more than one technique, you have a plethora of different interventions from manual therapy, exercise rehab, active rehab, psychological interventions. You are a dangerous weapon because you can do a lot of other stuff. And I just think those types of therapists will force the narrative of that patient to fit the treatment technique that they want because it's easy. They're lazy and they're not thinking critically.
Yeah, and if you're a hammer, everything's going to look like a nail. And
yeah, exactly.
And what you end up seeing is that justifying the treatment through would be a biased lens. And for those that may say, well, everyone's got their own biases, like including us, we're biased towards this or that. Me and Luke tried the chiropractic way. We absolutely wholeheartedly tried. Head down, butt up, studying our ass off, trying to connect the dots, trying to believe it, trying to make it work, trying to squeeze it into some clinical rationale, this philosophical, outdated 140-year-old ideology around how to treat someone and squeeze it into a 2025 clinical rationale. We tried, it didn't work. So we're not here casting stones lightly, right? This is what we believe. This is part of how we treat. And so it's important that we have these discussions. Okay, so we're going to move on to evidence of efficacy. Obviously, as Giles said, there's a very comprehensive review in the book. Despite some individual studies, the overall evidence from high-quality trials and systematic reviews consistently shows that spinal manipulation is inconclusive at best and often provides no benefit for pediatric conditions, with strong evidence of no effect on cases like asthma, headaches, and nocturnal enuresis. This raises serious questions about its appropriateness and effectiveness in children. When we look at the spectrum of research, I'm talking inconclusive on ADHD, autism, asthma, cerebral palsy, prematurity, cranial asymmetry, postural asymmetry, scoliosis, torticollis, upper cervical dysfunction, constipation, colic. I can go on and on. Clubfoot, cuboid syndrome, headache, lower back pain.
I'll give you an example. In the United Kingdom, if you were to put on your website that manipulation will treat one of those conditions, you will get prosecuted by the Advertising Standards Authority for misinformation. And that's in the UK. You're just not allowed to advertise that stuff because you just cannot prove its efficacy.
I wonder why the board exams are different, Brogan. Like most people going from NZ to UK fail them because they can't comply with a more mechanical approach.
Yeah, in fact, if you follow what would be a subluxation only approach in the UK, you're likely going to come into issues with your governing body. So it's pretty real stuff. But there's a lot of conditions, there's a lot of literature on this, and it's interesting to see like, hey, it's inconclusive or strictly no benefit, but let's go a step further and let's look at the safety, right? So, okay, well, if the evidence is not there for its efficacy, people can still say, well, it's case by case, or I provide this, or certain providers may provide a different way of doing
anecdotal evidence,
or it might be a friend of a friend, or it might be a family member or someone in the community you trust, so you take your baby, because hey, look, there's no adverse reactions. It's just there's no research on it. And sometimes people say, well, evidence is outdated and it takes time, and it's the three-legged stool. It can't just be about research papers, but it has to be about the patient. So okay, well, let's look at adverse effects. Let's look at adverse reactions. Adverse events following spinal manipulation in children have been reported across a wide range of conditions, from colic to bedwetting, headaches, and scoliosis. Lots of them. Reactions range from mild soreness to increased crying to serious and potentially life-threatening complications like rib fractures, subarachnoid hemorrhage, respiratory failure, and paraplegia. Notably, these events occur under the care of chiropractors, chiropractic students, manual therapists, physiotherapists, and even medical practitioners, raising critical concerns about training, oversight, and risk management. I wasn't attacking certain professions there. That is what our research showed. That's why I mentioned that. While some studies report no harm, the lack of consistent safety data and several alarming case reports make it clear that spinal manipulation in children should be approached with extreme caution, if at all. When I look through the research that we've done, again, we're looking at adverse reactions, headaches, spine pain, stiff neck, hot skin, dizziness, vomiting, facial weakness, double vision, ataxia, all the various adverse events of increased crying, bradycardia, tachycardia, reflex apnea, vegetative state reactions, potentially life-threatening rib fractures, respiratory failure, irritability, soreness, torticollis, unsteady gait, poor coordination, hospitalizations, neuromuscular deficits, clonus, paraplegia, subarachnoid hemorrhage, as I mentioned before. I mean, this is insane. In fact, a 3-month-old girl died from subarachnoid hemorrhage. Unclear if it's linked to the presenting condition or the treatment, but it happened under a physiotherapist. This is crazy to look at these adverse effects. I mean, if you are a evidence-based or evidence-informed practitioner and you're looking at this and you're going through this research, how can you come out of this and say, hey, I think it's safe to go ahead and crack a baby? I think the average person is going to say that's not wise, it's not safe. I think the average person, if you stop them on the street and you said, hey, should we crack babies? Should we crack their neck, crack their spine? I think the average person is going to say no, okay? Let's just go from the base position that is not okay. Well, what about other stuff? What is okay, if okay? And I'm interested to hear your thoughts on this, Giles.
Back in the COVID era, I posted a lot of face-to-camera videos, and I posted one up basically saying, don't crack kids. I said, cracking kids is not going to help with their autism, bedwetting, cognitive development, all of this stuff. I said basically what you've just reiterated. I said in a face-to-camera podcast, and I actually got slated by chiropractors saying I manipulated my newborn son's OA back into position, and I've done this and I've done that. I got massive amounts of feedback, some positive, lots positive, lots negative. So turning around and saying everyone should have a degree of common sense, you hope they do, but unfortunately it's not always the case, because if you're trained in a certain mindset and you're not prepared to critically think or potentially change your mind based on the evidence out there, again, you're going to be indoctrinated in that way, and you're going to, again, if everything's a nail, you're going to freaking use a hammer. But the reality is, it's about risk versus reward. Risk versus reward. What is the risk to this person, this child, this infant, versus the reward of, and let's be fair, temporary neurophysiological modulation of symptomology or functionality? Right? I crack something, you'll move a bit better for a short period of time. We know this, right? I'm not going to have these massive changes that they're portraying. So the risk versus the reward, which means we have a massive amount of stuff that we can do, from soft tissue techniques, from fascial work, from gentle mobilization stuff, which is all movement based. Now, I don't personally do eccentric cranial type stuff. I don't like it. I don't do it. There's no research around it. But that being said, some of my colleagues have done it. They've had some great results. As long as they're safe and ethical, I have no issues in you doing that, as long as you're not lying to the patient's parents, giving them or promising them things that they can't deliver. So you have a whole scope. With kids, I'm a massive fan of active rehab. Rather than trying to get them on the manual therapy table, I'd rather you exercise and rehab them in that type of way, because the kids, I just think they respond better to that type of treatment modality. I just think exercise rehab is much better for that type of demographic. So yeah, mobilization, soft tissue work, and we know that mobilization and manipulation will achieve the same outcome. So why am I going to bother trying to crack the back of a kid when I can mobilize and achieve the same without potentially causing them significant distress or potentially more underlying problems? I just think with that demographic, safe clinical thought process and safe techniques are going to be key at all times.
And what you're saying is right, of course. Like, why would you do that? Because, we know that you can get the same neurophysiological outcome from various techniques, but then there'll be people listening to this that would dispute that. And they would say, well, no, that's not the case, because the chiropractic adjustment is special and it's different, and we are targeting. And
what are you, Harry Potter? We've disproven targeted manipulation. We've disproven precise manipulative abilities. We know that the idea about Gonstead lines of drive is outdated pseudoscience. We know that manipulation is non-specific. It's specific to a certain area, but you can't be specific to a joint. So you can argue all day long, but the reality is, especially with kids that are still growing and forming, you're hoping you're hoping for the best anatomically when you're applying techniques to a child. So all of that specificity and that precise chiropractic sniper adjustment is absolute fucking nonsense.
Yeah.
So, I knock it out the park. Don't come to me saying chiropractic adjustment and spinal manipulation are different, because they're fucking not. A joint is doing that, whether it's done by a chiropractor or a fucking bus driver.
Chiros love fighting over the nitty-gritty semantics.
It's virtue signaling, because they're trying to justify their name, their title, and their degree. It's just like, sorry, I'm an osteopath. I always remember my lecturer going, "You don't do soft tissue, you're an osteopath." I'm like, "You don't do massage, you're an osteopath." I'm like, just because I'm wearing a title that says osteopath, I'm still rubbing the skin. It is still massage. So it's all ego. Ultimately, it's all virtue signaling ego when people start using that type of comeback.
Yeah, it's because the philosophy behind what the chiropractors claim they're doing, right? Like removing nerve interference, of which is occurring through a subluxated segment. If we look at the educational component of this, though, that there are even more concerns, because obviously I agree with what you're saying, and the points you raised, Giles, were very, very good points. It's concerning because when evaluating spinal manipulation in a pediatric population, it is crucial to consider the level of specialty training that these MSK healthcare practitioners receive. While the average person may think receiving any pediatric training is a good thing, it actually isn't, right? Especially when that education or that training is very limited or superficial. I believe it can foster a false sense of competence in this professional. This in turn may encourage practitioners to treat a demographic that falls outside of their true scope of practice, and this is my opinion. True pediatric specialists will undertake several years of postgraduate education, equipping them with advanced knowledge and clinical experience and all the required safety and understanding to effectively treat children. So what do I mean by this? Within the chiropractic program, and Luke can speak to this as well, there's one pediatric paper.
Pretty sure it was only over 8 weeks.
Yeah, so there's one pediatric paper. Within this paper, you learn some basics, this and that. The issue here is that chiropractors graduate after 4 years or 5 years, and they are encouraged to treat a pediatric population based on that one paper that they have done. They are told that subluxation occurs through every stage of life and that you can specialize in anything when you graduate with no extra training. Now, if you want to go call yourself a sports chiropractor and put that on Instagram and play with yourself, that's fine, right? Whatever. But when it comes to treating such a sensitive population such as pediatrics and children and babies, I think we are creating this false competence through these papers. If you want to do the training, that's fine, but the communication around it must be ethical and honest around what you can do. My belief system would be, I'm interested to hear you both, is that if you are an allied healthcare professional and you have gone and done the sweat, tears, and years, and you've done the postgraduate training in pediatrics, then and only then can you be the one making the decision, how do I want to treat a pediatric population? I don't think as standard allied healthcare, so just let's say a physio, a chiro, and an osteo, or an EP, graduating at that level, going in and specializing directly after that, I don't think that's appropriate. What are your thoughts?
Firstly, touching on that course we did, I don't think it was in there to teach us. Like, I don't think the main priority was to prepare us for dealing with pediatrics. I think it was purely a board placed thing where, okay, we have to chuck an 8-week course in, to basically tick the boxes before you leave to cover yourself as a practitioner to be able to treat babies. Because I probably felt worse coming out dealing with a baby than I did going in. And then, secondly, moving on to, whether we get into post-grad stuff or whether it's seminar work, I'm a bit of a mixed bag. Like, it depends what we're talking. HVLA, sure, I'm fully against that in pediatric and infants, but if there are like low force, non-invasive techniques that you can learn over a certain period that can help with certain things, I don't know what it may be. Maybe a restriction in an infant turning the head, for example. I don't think there's going to be much harm in that if you're using very low force techniques, whereas maybe like some very gentle mobilization stuff. Because if we're looking at post-grad education, like, just from personal experience, I know duration doesn't determine the quality of content and things that you learn. So just because you go into a 2-year postgrad degree doesn't mean you're going to come out better. Because I felt that with chiropractic. We went through 5 years. I feel like it could have been reduced down into maybe 1 or 2 and come out with the same level of competency, if not better, because if it was taught a lot better and not stretched out over that time, with all the sort of flaky sort of content in there. But yeah, I think it does depend, because there are a lot of specialties when it comes to pediatric based clinicians. I'm not too sure on what a lot of them are, but I know it's leaning more towards that medical side, where I think as an allied health practitioner dealing with that demographic, you need to have a fair understanding about a lot of that stuff if you're to deal with that. So I think just applying an activator to a baby's neck isn't enough, in my opinion.
Yeah, and
that's what I'm saying.
So when I said like you have to do this much study so you get the what I mean is when you've done this much study, then you get the right to decide how to treat. I'm not even saying spinal manipulation or mobilization. I'm saying because really the training is teaching you when not to treat. So if you say like, okay, I'm not okay with HVLA, but I'm okay with LVLA, well, you're still saying after 4 years of training, you're okay with the allied healthcare practitioner making decisions on how to treat your baby. That's what you're still saying. So like, I understand I agree with what you're saying in many points, especially the one about, well, duration doesn't mean quality. That's so true. But for me, I'm trying to, like you have to settle somewhere. Like for me, I'm like, okay, I can't be completely unrealistic and say no pediatrics ever. And I know Giles can speak to the postgraduate training because he has a colleague that's done it and she's fantastic. But for me, it's not just about how they're treating, but it's having the decision to treat or having the decision on how to treat. Just to get to that level, you have to understand babies, and you don't get that. You don't have the anatomical or the physiological or the neurological understanding of a baby and the differences of a baby. I mean, even just looking at the physiological differences, complete ossification and skeletal development are not typically achieved until the approximate age of 17. These anatomical and developmental differences underscore the need for extreme caution when applying manual therapies to young populations, compounding the concern in this notably inconsistency. I mean, there's significant variability in the amount of force practitioners use and how they report it, but there's all these differences that come with treating a baby versus an adolescent versus a teenager versus a full-grown person into geriatrics. So like that would be my opinion on it. It's like, okay, that one paper that you're doing is not enough to even know who's who in the zoo, if that makes sense.
Exactly. Yeah.
And so it's so difficult to even know, should you manipulate, should you dry needle, should you not do those things, should you LVLA, should you activate it? Really, you don't even know how to refer at that point with baby stuff.
Yeah, that's the thing I would say too, is like, if you don't know what to do, you should be referring. Even on the Australian Health Practitioners Agency Act, it basically states, it says, when chiropractors do not have the clinical skills and knowledge to appropriately assess or manage a pediatric patient, the board expects them to refer the patient to another healthcare practitioner who have the appropriate skills, or to co-manage the patient with the other healthcare practitioner. But I don't think most chiros do, right? Like that's what the philosophy is to take everyone on board.
You do make a very valid point, Luke, about the duration of the course not necessarily engaging in good quality education. So I will agree with you there. I would say you're talking about the Dunning-Kruger effect. A little bit of knowledge is a dangerous thing. And having done a 5-year degree or a 5-year master's in osteo, physio, chiro does not give you the license to treat everyone and everything. And if you think you can treat everyone and everything, then you are deluded. You are absolutely deluded, because the qualification basically it shows that you're safe. It shows that you have a level of anatomy, a level of clinical thought process. You can do some testing, you can do some technique, you can treat generally, but that's as far as it goes. It shows that you have a level of competency that you can pass some exams and you're not a complete dimwit that's going to cause problems. Well, you might do, but you have a base level. Yeah. I would say if you are looking to treat special population groups, right? Infants, potentially geriatrics, maybe pregnancy, then it is worth investing in postgraduate education. It's worth investing, whether doesn't matter where it is, as long as you do your research and it's good quality education. Personally, I think if you're going to treat infants, it's a 2-year postgrad course. I think you should be engaging in postgraduate education, Because from my perspective, what I would fear the most is missing something. I graduated after 5 years of osteopathy. I wouldn't have a clue how to treat a baby properly, because it's about screening that child. It's about making sure there's nothing serious there. And with kids, just like with pregnancy, there is so much that you can get wrong and put that person at risk. So for me, I am a big believer in either referring to people that know more than you do, letting them assist you, co-helping with another colleague to co-manage a patient, being open to ask for help and advice. I personally don't treat babies purely because I would be absolutely devastated if I missed something. So for me, and this is a personal thing, I am very open that I can't treat everyone and everything. I am not Harry Potter. I'm not Superman. I'm pretty good at MSK. You give me MSK, I'm pretty damn good at it. But outside of that, because there's so much complexity and so much risk, could you imagine the parents bring a baby to you and because for some reason they're concerned it's not sleeping properly, and you just start, engaging in manual therapy, but there's something underlyingly wrong and there could be some significant problems. I don't know how you could live with yourself. So that's why, like you said, and Brogan, I think the postgraduate training gives you the ability to pick up red flags, to help you really understand case history and screening. Look, the techniques are the techniques. Rub it, wiggle it, move it, stretch it, rehab it, spin it around, do some cranial, whatever you're going to do. I don't care. But as long as you have that good knowledge of when not to treat, that to me is more important than learning how to crack anything. It's learning when not to. So for me, I'm a big believer in postgrad education because you'll never lose on it.
Yeah, even if that postgraduate education is not perfect or it has issues. And then there's also some gray area, I suppose, for parts of the world where if that's not possible, for people to do seminars and to like build up over time and become more experienced. But it's more of a gray area. And I can't sit here saying how much is too much and how little is too little. It's not my job. It's not my role. I'm just sitting here saying this is a rough guide of what I would feel comfortable with ethically. What about the formal guidelines, Luke? Do you have any insight on the formal guidelines?
I was looking at more at the board stuff of what the board had to say with practicing on pediatric. So just quickly with New Zealand, I looked on the chiropractic board and honestly, there's not a massive write-up on a lot of the stuff on the demographic, but I will read one section that they do have on pediatrics and infants. Basically, it states that, which we've already talked about before, chiropractic focuses on the relationship between the spine and the nervous system. This is especially important for children as the nerve system develops. What we now understand with regards to brain development is that the first few years of life are paramount for optimal nerve system growth. With this in mind, assessing and facilitating the removal of nerve interference is something we should be aiming for in all Kiwi kids. The chiropractor is trained to assess the spine for evidence of dysfunction and nerve interference to promote optimal brain-body communication, blah, blah, blah. So with that being on there...
That's the board.
Yeah. There's no... Like I couldn't find any guidelines like similar to different to Australia where they're actually restricting practicing on certain age groups. So that statement to me basically says like it's free for all pretty much. Do you know what I mean? So whereas we look at Australia, I did want to read the part about what happened with that chiropractor in Melbourne. Which basically led to a lot of the restrictions. So this year they basically stated 2019, first of all, was when the board released an interim policy of spinal manipulation of children under 12 years. They basically looked at a lot of systematic reviews of the effectiveness and safety of spinal manipulation in children under 12. The board published updated guidelines in line with its findings in November 2023, allowing chiropractors to treat children according to current evidence and or best practice approaches, which they didn't state. But the reason why that interim policy was brought in 2019 was because there was a Gonstead chiropractor in Melbourne. He was basically posted a video that went viral over YouTube adjusting a 4-year-old's baby's back, I think, or maybe 4-day-old. I can't quite remember.
It was an infant, like he was only
Through
4 days old.
yeah, through the thoracic area, posted it online, and yeah, the media came down hitting him hard. I don't think there was any adverse effects reported. It was just more the fact that he had posted the video. He was basically banned from practicing chiropractic on any age for about 2 years. And then 4 years later, re-updated the policy and changed it to, it is now currently under 2 years of age. So no spinal manipulation to, under 2 years. And it's basically pending further consultation with all the Australian health ministers. So it's pretty much ongoing at the moment. But I guess they're just looking for current evidence and seeing what comes out with that and things like that. But that's pretty much what I found.
Yeah, and what I can see with just doing a quick search as well is that for the most part, in terms of actually suggesting or guidelines around treating, there are no major guidelines that are going to suggest to spinal manipulate or adjust infants in that manner. However, there are some governing bodies around the world that have placed restrictions, which I think is the right thing to do. Otherwise, they have opinions, but it is a little bit of the Wild West, and that is certainly concerning, isn't it?
100%. Yeah.
But I think it's a massive problem. I mean, the only saving grace is that you've got regulated countries that are trying to put in some form of regulation or some form of common sense restrictions, but there's only a few. I mean, let's be fair, osteochiro is only a regulated, protected profession in only a handful of countries. Outside of those, there's people calling themselves osteos, chiros, and bone setters doing some crazy stuff without any thought process or any guidelines whatsoever. So it can be very, very challenging, for that sort of stuff.
What I'm reading here is that many of these governing boards, especially for children under 12, are saying that it's unproven, not medically necessary for diagnosis or treatment, citing insufficient published research to assess the safety and the health outcomes. So, there's a lot of stuff around.
I think you've got to have common sense. So when we teach, we always turn around to students, because we get this question a lot: what's the youngest we can crack? What's the oldest we can crack? But I get it every time we teach, and I have a blanket statement I follow, and I turn around and go, look, if you've got someone under the age of 12, use another modality, soft tissue, mobilization, whatever it is you're going to do. Don't manipulate them. Under the age of 12, you can achieve the same outcome, something else. Between the age of 12 and 18, firstly, that you need an appropriate adult or some form of parent or guardian in the room at the same time. But it's going to be done on a case-by-case basis. You can have a 12-year-old that's 6'5" or a 12-year-old that's tiny.
Yeah.
Over the age of 18, you pretty much, are good to go on what the patient is expecting and that sort of stuff. But for me, it's a sort of a sliding scale. Under 12, it's a no-go. 12 to 18, it's a case-by-case decision with you and the parent on shared decision-making. It's not down to you alone. It has to be a discussion between you, the parents, and the patient as to what modalities are appropriate, risk versus reward. And then 18 plus, they're an adult, and it's a bit more of a freer area.
Yeah. So to conclude the podcast, I'll get let's go around and just give our final thoughts on it in terms of our actual personal opinions, because we've been talking, and you can probably figure it out by now if you've been listening to this podcast, our personal opinions, but I think at least we can state that, and maybe also state whether or not you've ever treated kids. I haven't ever treated infants or anything like that. Obviously, I have 2 young kids, but in an official capacity, no, I haven't done that. I do believe that if you've made the effort to do official postgraduate training in pediatrics, if you are being ethical in your approach, if you are communicating clearly the risks versus the rewards, you're clearly communicating the potential health outcomes, whether they are positive and negative, and you are doing interventions that are not high velocity, then I think that is potentially okay. That would be my final say on it. I don't think outside of that there's much wiggle room, apart from, again, there may be situations where you can do seminars and you can upskill, doing mentorships under certain people. I do understand that there are chiropractic businesses that specialize in pediatric care. They do more soft touch, soft tissue. They care for the mothers. There's a lot of other stuff that goes into it. I'm not saying that that's on its face wrong. Like, I think there may even be a place for that where mothers can come and feel safe, and you're getting like an aspect. It's almost like a community that you're getting that aspect of like a yoga class, or, you know, like a Pilates class. You know, you're getting this aspect where you're getting a health intervention, and you're having somewhat connection with some people, other women, when you're going through this emotional time, you've got a baby. That potentially may be helpful, but I just think you got to be real careful on the communication, the advertisement, and the ethical boundaries around that. What do you think, Luke? And then we'll finish on Giles.
Yeah, so 2 points. I want to go back to briefly what we were talking about before the postgrad, because I think I sort of misunderstood the question. I agree with the postgrad in terms of, yes, when you're talking, you know, history, red flags with children, we were not taught any of that at college. So to be going in and treating children without an understanding of anatomy, physiology in an infant, for sure, 100% agree with. I think where I was coming from was just like techniques, right? Giles touched on, you can twist, rotate, slap, whatever. It may only take like, you know, a couple of seminars here or there to learn a few effective techniques. But in terms of like practicing like safely and caring for pediatric, yes, I think a postgraduate diploma is like a must do for sure. In terms of treating children, I've only ever treated a 9-year-old and a 12-year-old. The 9-year-old was a hip impingement related thing anyway, so it wasn't even spinal, but she was a dance child, like doing so many hours a week. The other one I treated was a 12-year-old, and he actually had a neck complaint of tension-based headache. So yeah, I didn't manipulate him. I focused on more mobilization techniques and then purely exercise. Like we just don't see young children in our clinic. So it was a first time for me, and I was actually really surprised with how effective the exercise stuff was. So I worked on, a lot of self-administered mobilizations and then activation work, particularly for up around the suboccipital region. And he was pretty sweet after 1 week, man. Like just basic headaches at school. So
I have no issues in people treating babies and children if they've done postgraduate training. If you've done the training, treat the kids. And I've got colleagues that work with mothers that do some fantastic stuff. But those girls and guys have done an extensive amount of training. So I have no issues with that whatsoever at all. I've treated lots of children over the last 15, 20 years. I don't manipulate kids. I think personally, if you're going to do manual therapy, mobilize it, do some soft tissue. That's cool. If you want to do something on the table, that is fine. I would avoid acupuncture because they're going to get traumatized with you trying to stick needles in them, especially if they're kids. And I wouldn't use manipulative technique because I can do the same thing with mobilization. Personally, I love active rehab. Like you said, Luke, I work with my colleague Stephen Goldrick, and there's a couple of other PTs in the gym that I do the calisthenics with, and they specialize in training kids. The results they get are phenomenal, fantastic. Active rehab, strength work, self-mobilization, there's lots that can be done. And when you work with exercise professionals collectively, you get fantastic results. Taking the treatment off the table into that form of type of process is massively important. I'm not a massive fan of just passive interventions with children. I just think we can do an awful lot more. So that is my view on it. If you've done the training, crack on, man, do your thing. But if you haven't, go and do more training or refer to someone who has.
That was good. I agree. I think for the most part, we're on similar pages. And I don't know what you were saying, Luke, and what you were meaning. I just wanted to highlight for the listeners, obviously, those extra thoughts. It's an important discussion, and we went a little bit long, even though I was hoping to be on time. But once you get talking about this stuff, there is more than you realize to unpack. If you want to know more about it, be sure to follow OMT Training. Be sure to follow us at the Rehab Professionals on Instagram, on Facebook, on YouTube. Be sure to listen to the podcast anywhere you can find good good podcasts, and be sure to pre-order the new book that is coming out, OMT's new book. Go ahead, Giles, give us a look at it one more time. We're really proud of the work that we've done on this. Giles, obviously, absolute workhorse.
Although, to be fair, within this new book, not only do we talk about spinal manipulation and children, but we also talk about the importance of why you need to combine it with exercise rehab. And you guys have done some fantastic chapters in here, looking at things like X-rays and validity of that and other bits and pieces. And it was a great project. And I think what's nice is, three professionals, maybe different backgrounds, but coming together with similar thought processes.
Yeah, it was a great project to be a part of, and I really hope people do go out and get it, buy into it. Otherwise, if you don't, you can listen to our podcast and get the the cliff notes. Otherwise, be sure
just rip it off anyway. Don't worry, it'll be ripped off on Facebook within a week.
Something I have been doing is including a link below with the show notes. I've done it on, where they're needed, when we've been referring to graphs and tables and research. So I'll go ahead and include show notes in this one. So it'll be below. You can click that and go through that. And once again, critically think, go through the studies, read it for yourself and make a decision for yourself. But I think for the most part, there's a lot of common sense going into this discussion. Unfortunately, certain people may disagree with that, but it is what it is. Otherwise, we will leave it there. Have a great night, Giles. And it's the start of the day for me and Luke on this side of the world. So we're looking forward to a great Monday. Good night, mate. And we'll see you guys next week.
Later.
See you, Giles. Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, so welcome to the Rehab Blueprint podcast.